Hello, and welcome to Basics to Brilliance Haematology Podcast, the podcast series that will take your basic haematology knowledge up to a level needed to be an effective haematology registrar. We hope that the content we cover here will help you prepare for the dreaded Haematology FRC Path Part 1 examination. But most importantly, we hope that this series fills you with excitement for the fantastic, dynamic and highly rewarding specialty of haematology. My name is Dr. Anharad Everden, Haematology ST5 Registrar in the South West Deanery.
And my name's Dr. David Fazy, Haematology SHO, with aspirations to be a haemareg.
And let's get started on today's topic.
From basics
to brilliance. Okay, so today's topic is CLL, also known as chronic lymphocytic leukemia.
Okay, what's CLL?
Well, CLL is firstly the most common leukemia in adults, so an important topic to talk about. And it has a median age of 72 years, so it's generally a disease of the older patient, slightly more common in men than women, but essentially it's a chronic relapsing and remitting leukemia, so i.e. it's not curable. So that's kind of what it is in a nutshell. You may have also heard of the term SLL. Do you know what the difference is between CLL and SLL, David?
The only thing I know is the S stands for small. I've never heard it clinically.
Yeah, fair enough. So CLL stands for chronic lymphocytic leukemia, and that's because the lymphocytes that are in question are found in the blood, and therefore that's why it's the word leukemia. And likewise, if you have cytopenias, which we'll talk about later with the lymphocytosis, then that would also be a diagnosis of CLL. But the other thing that it can be referred to as SLL, which is small lymphocytic lymphoma. And that basically has exactly the same morphology and phenotype and sort of disease process. But instead of the lymphocytes, the abnormal lymphocytes being in the blood, they're just in the lymph nodes and the spleen. And so that's the difference. And that's why it's called a lymphoma. So you wouldn't have a significant peripheral blood lymphocytosis in SLL. But patients can get kind of quite hung up on whether they've got CLL or SLL. Essentially, I explained at the beginning that the terms are used interchangeably and it doesn't really change management for the most part.
That makes sense.
Cool. Just starting off with basics, how does CLL present usually, David? Do you know?
From what I understand, most of it's an incidental finding. Someone comes in for a routine set of bloods who's been fatigued or something and turns out to have a white cell count of 50, and invariably a GP phones a haematologist.
Yeah, absolutely. So over 80% of all CLL is a complete incidental diagnosis on a full blood count. But sometimes it can lead to people feeling quite fatigued or sometimes having B symptoms. So that's fever, weight loss, sometimes drenching night sweats, reduced appetite and other constitutional symptoms. And then sometimes CLL can cause cytopenias, so low red blood cells or low platelets, which obviously can then lead to symptoms of anemia or easy bruising and bleeding. And the reason why you can get cytopenias in CLL, there's a differential of why. One is heavy marrow infiltration, so that the bone marrow stem cells don't really have the space to be able to do what they normally do and make the cells that you need. But also those abnormal lymphocytes can trigger autoimmune diseases, in particular autoimmune hemolysis and idiopathic thrombocytopenic purpura, of which we'll do separate podcasts on, but essentially autoimmune destruction of your red blood cells and your platelets. And then sometimes if you have a lot of disease from your CLL in the spleen, which is less common, then I guess also you can get low counts from having hyposplenism, where your spleen is just becoming bigger and bigger and munching up your cells. So those are the ways in which CLL can present, but most of the time it's completely coincidental.
Okay, so say I found someone, I'm concerned that they've got, they're fatigued, I've got this hideous looking white cell count. I want to refer to a haematologist. What should I be investigating first?
Yeah, so I guess obviously we'd start with a full blood count. And in particular, I would just highlight here that on quite a lot of my on-calls as a haematology reg, you can get phoned by someone, usually of the medical team. Someone comes in with a white cell count of, 200, and it seems very alarming. And just to say that these are lymphocytes, so they're very small, and therefore you can tolerate very high white blood cell counts. On their own, they're not going to necessarily cause issues. And so that's just something to say, which is in contrast to, if those white cells were blasts, or if they were a myeloid condition like chronic myeloid leukemia, the kind of counterpart of CLL, the chronic lymphocytic leukemia, where you may well get quite a lot of symptoms from having a high white cell count. Then you'd also want to do a blood film. And what you're looking for there is small, mature lymphocytes. And a blood film can be really useful to distinguish between the typical appearances of CLL, where they're just small, mature lymphocytes, compared to a reactive lymphocytosis, for example, in a viral infection, where often the lymphocytes will be seen to be kind of scalloping the red cells, so kind of almost trying to engulf the red cells, it looks like, and that can be useful. And you're going to want to look at a trend to see how long the patient's had the lymphocyte count for and what speed it's going up. Other blood tests you might then want to do are things like a hemolysis screen, particularly if the patient's anemic. So for that, you would do a direct antiglobulin test, which may be positive, a reticulocyte count, which may be raised if there's hemolysis, because you're having to compensate by making more red blood cells. You would also do a split bilirubin, an LDH, a urate, and haptoglobins, which are all hemolysis markers.
That direct test that you mentioned, is that a Coombs test?
Yeah, that's right. It's the same thing. So it's a direct Coombs test, yeah. And it's basically it's a lab test that we'll go into more when we talk about various transfusion topics and autoimmune hemolysis. But essentially, it's a test that looks for the presence of antibody-coated red blood cells through agglutination. So then other investigations you'd want to do would be a beta-2 microglobulin as part of your prognostic marker. You're going to do viral serology, which is generally something you should do in anyone you suspect has a hematological problem. So hepatitis B, C, and HIV serology. And then the other thing you're going to want to do is immunoglobulins and serum protein electrophoresis, which we will talk about more when we talk about MGUS and myeloma. But in the context of CLL in particular, we do that to look for evidence of low antibody levels in a patient due to CLL, because that can give us an indication of how impaired their immune system might be from this condition. And then the other important, more specialist test would be something called flow. Have you heard of flow at all?
So flow cytometry. So
yeah,
looking at the cells themselves and looking at their sort of size and granularity and things like that.
Yeah. It's also known as immunophenotyping. And essentially what it does is look at the markers on the surface of your white blood cells. And that can be really informative to tell you what is the identity of the white blood cell that you've identified on your raised white cell count on your full blood count. Just very briefly, how it works is you have antibodies labeled with various colours, is how I think about it. So let's say an antibody against CD19, CD20, for example, and you incubate your patient blood sample with those various antibodies with their coloured labels. And then you basically put them through a machine where a laser will be shone at the white blood cells, and then a particular colour will come off dependent on what antibody is bound to the white cells. So it allows you to see what's on the surface, basically. So that's really useful for CLL, and we'll talk about that a bit more when we talk about confirming the diagnosis. Things like a lymph node biopsy, you might want to do that, particularly if your patient is somebody that presents with significant lymphadenopathy, but not much in the way of lymphocytosis, for example, and you're thinking about SLL, then that would be important. And it's always important to get a core biopsy rather than an aspirate, so that you can see the structural architecture of how the B cells are arranged. And then if the blood count was reduced, so you said your patient, I think you said that your example patient had a lymphocytosis and was possibly anemic. If that's the case, then we may want to do a bone marrow biopsy as well. And basically that's to look to see whether the anemia is due to heavy marrow infiltration with CLL, of which you would have other clues like a low reticulocyte count, which would tell you that there's an issue with the production of red blood cells. But then doing a bone marrow biopsy would be really helpful to confirm that. And then finally, I guess one of the other really important investigations before every line of treatment, when you're thinking about a CLL patient that does need treatment, is to test for a particular mutation. Do you know what that mutation is?
Are you referring to the guardian of the genome, the P53?
Yes. Excellent, exactly.
Yeah.
So TP53, either deletion, which is the 17p deletion, or mutation. Both of those are important to identify because they are prognostic and they are starting to influence management as well. And then before treatment as well, you may also want to get a CT scan, but I wouldn't be routinely doing a CT neck, chest, abdomen, and pelvis at diagnosis because it's not really relevant at diagnosis until you're at the stage where you actually think the patient needs treatment.
Okay, so we've got a lot of investigations that we've done. How do we confirm that someone has CLL?
Yeah, so that's a really good point. And essentially, there's three key things that you need to have to confirm a diagnosis of CLL. The first one is lymphocyte morphology, which is why the blood film is really important. So this is that the lymphocytes that you see on the blood film are mature looking, which means that they've got quite clumpy chromatin within the nucleus, and they're quite small and they don't look like reactive, as we said before, and that they have no nucleolus within the nucleus. Because if you have lots of lymphocytes that have nucleoli, then you think about them being pro-lymphocytes, which are a bit more aggressive than your standard small mature lymphocyte, and used to be described as being B-cell pro-lymphocytic leukemia, which is actually a diagnosis the WHO in 2022 removed and reclassified. But it's still important to therefore make sure that you've got less than or equal to 15% pro-lymphocytes. So the vast majority of lymphocytes need to not have a nucleolus and look small and mature.
Okay. Sorry to interrupt, but how would you sort of differentiate that from a reactive lymphocyte? What's that doing that sets it apart?
Yeah, so a reactive lymphocyte is reacting to an infection, or particularly viral infections. That's the role of lymphocytes. And they can have quite prominent nucleoli, and some of them can look really quite scary under the microscope in things like acute EBV infection, for example, and glandular fever, where they can have a big nucleolus, but they classically have lots of cytoplasm, and the cytoplasm scallops around the red cells, and they can look quite different from each other, as we describe the lymphocyte morphology in CLL as being monomorphic, which means that the lymphocytes all look really similar and small and mature.
Okay, thank you. That makes sense.
Obviously, your trend would also help you to distinguish between what might be a viral reactive lymphocytosis versus a more persistent chronic picture in CLL. So that's the lymphocyte morphology. The second thing that you need is that you need more than 5 × 10⁹ per litre circulating clonal B cells persisting for more than 3 months. So what I mean by this is that, so what do you understand by clonality?
I guess from a single clone, it started off from one cell that has then split, as opposed to multiple things have been activated and produced slightly different lineages. Yeah,
exactly. And we can look for clonality in B cells quite easily, because B cells normally will have 50% kappa or 50% lambda light chains expressed. And so we should have a nice 50-50 split in health normally. So if you find a population of lymphocytes and they're all kappa or they're all lambda, what we describe as kappa or lambda restricted in their expression, then that gives us an indication that they are clonal, that they've derived from one cell. And the other, and so we can look for that clonality by doing the flow cytometry that I talked about to see whether they're expressing kappa or lambda. And flow will then be reported from the lab as a percentage of cells that are kappa or lambda, are clonal. And so then what you have to do is take your total lymphocyte count that you've got from your full blood count. So let's say we had lymphocytes of 10 and the flow was reported 70% of lymphocytes are clonal. Then therefore that 7 of those 10 lymphocytes are clonal, and therefore that's greater than 5, and that meets the criteria of more than 5 circulating clonal B cells. Does that make sense?
Yeah, got it.
So it's a bit of basic maths, but
yeah. Even I can get there.
Yeah. So the reason why I highlight this is because if the clonal lymphocytes don't meet the greater than 5 threshold, then you have some different kind of terminology for what that would be. So if you had, let's say, 4 clonal lymphocytes floating around in the blood when you get your flow result back, then that's called low count. Oh no, that's called either CLL/SLL type monoclonal B lymphocytosis or non-CLL SLL type monoclonal B lymphocytosis. So essentially it's saying that you've got a monoclonal B cell population in your blood plasma, but it doesn't meet the threshold for CLL. And that's relevant because they probably just need an annual full blood count monitoring, because about 1 or 2% of monoclonal B lymphocytosis will progress to CLL, which may then go on to need treatment in the future. You can also get situations where the percentage of lymphocytes circulating in the blood are very low, and so you have less than 0.5 clonal B cells, and that's called low count monoclonal B lymphocytosis, and it probably doesn't really need monitoring, to be honest. So that's your threshold. Okay. So you've got 1, lymphocyte morphology, 2, greater than 5 circulating clonal B cells persisting for more than 3 months. And then the third thing is this characteristic immunophenotype. And that's using flow cytometry again, but using this scoring system called the CLL score. And 92% of all CLL scores either a 4 or a 5 on the CLL score. And basically you score 1 point for the presence of CD5 positivity, 1 point for the presence of CD23 positivity, and 1 point for weak immunoglobulin expression. And then you also get a point for the absence or weak expression of CD22, also known as 79B, and the absence of expression of FMC7, which is usually more seen in mantle cell. And so it's that combination of, if you're getting a 5 out of 5 score, then you've got the 3 that are positive and the 2 that are negative. And you just basically have to memorize that scoring system. Okay. But it's really
Are those CDs and those markers present on most lymphocytes, or only sort of aberrant ones that are going down this sort of...
Yeah, that's a really good question. That's a really good question. And essentially it's a combination. So some of those markers you would expect to see on a B cell, and then some of them represent aberrant expression or aberrant lack of expression. And so it's just a scoring system that they've worked out that will allow you to, diagnose CLL if you score a 4 or 5 out of 5. And if you're scoring a 1 or a 2, then it's not going to be CLL, but you have got a clonal B cell population. So then it's about thinking about other differentials. So is it mantle cell lymphoma or marginal zone lymphoma, for example?
Okay.
So that's how you confirm CLL.
Grand.
So quite a lot there. So do you know about any staging criteria that we use for CLL, David? Have you heard of any at all?
I have, but I can't for the life of me remember them.
That's fair enough. So there are 2 different types of staging that we use, the Binet and the Rye classification. So with Binet, you're looking at dividing CLL into CLL stage A, B, and C. So A is where you have less than 3 lymphoid areas. B is where you've got greater than or equal to 3 lymphoid areas affected. And C is where you then start to get low counts, so hemoglobin of less than 100 or platelets less than 100. And in terms of lymphoid areas, you would count neck nodes, axillary nodes, inguinal nodes, and then hepatomegaly and splenomegaly score a separate point each. Okay, so that's the Binet criteria. And then you've also got the Rye classification, and that goes from 0 to 4. And it's based, 0 is when you've got lymphocytosis in the blood only and no lymph nodes. 1 is that you've got lymph nodes. 2 is that you've got hepatosplenomegaly. And then 3 and 4 are dependent on whether you've got, so 3 is that you've got a low hemoglobin of less than 110, which is unhelpfully 110 rather than 100 like the Binet staging, so a different number to remember. But then the platelet count being less than 100 is then stage 4. And
okay. Do you typically use both of those, or is that sort of trust dependent, or what?
Yeah. Again, to be honest, the utility of these staging things now is not that useful, because it's based on data on patients with CLL treated with traditional chemoimmunotherapy, which we'll talk about in a minute, but is not really what we use to treat CLL anymore. And so they can be useful for prognosis in sort of advanced stage CLL, but they're not very good at predicting prognosis for early stage disease. But just to give you a rough flavour, if you take Binet staging, low risk stage A disease gives you a prognosis of over 15 years. And to be honest, many people will die of something else other than their CLL if they've got stage A disease, especially considering these are patients that are older, so they'll have lots of other comorbidities. But high risk on the Binet staging, so stage C, will give you a prognosis of about 5 years. So we're talking a difference of greater than 15 years versus 5 years. So being non-life threatening to, potentially shortening your length of life. So it's useful for the advanced stage disease, but it's not very useful for early stage disease anymore. And it's kind of going a bit out of date.
So what I'm seeing, what I'm sort of reading here is that if there are cytopenias, regardless of the staging system, it's worse news.
Yes, yeah, exactly. You're right. And then there are lots of other things that we can use for prognosis now, in particular the CLL IPI. So that's the CLL International Prognostic Index. And there are 5 key features that it uses in someone's CLL disease to predict prognosis. So age is one of them. Beta-2 microglobulin, which we listed as part of our investigations earlier on, is another one. So raised beta-2 microglobulin, because it's made by the CLL cells. Although note that it is also increased in CKD, so be careful. The third one is then TP53 status. Like every condition in hematology, TP53 mutation or deletion is bad news, and will predict that they are less likely to respond to traditional chemotherapy, both in terms of response rate and progression-free survival. The fourth one is this other gene called immunoglobulin high variant mutation. And this one is weird because actually if you're mutated, that's actually better news, because if you've got the mutation, it means that the B cell clone has already met the antigen before and therefore is more mature than if it's unmutated, where it's not met the antigen before and therefore is less mature and has a worse prognosis. And then the fifth one in the CLL IPI is the Rye or Binet staging. And that's where doing either Rye or Binet is still useful so that you can plug it into the CLL IPI. And then I guess there are other factors that are not part of the CLL IPI, which are things like disease-related features. We used to look at CD38 positivity, which has the higher the expression, the worse the prognosis. But actually, that was before we could reliably test for IgHV mutation. And so actually, we don't really need to do that anymore. And then there are other genes that are associated with a poorer prognosis in CLL, such as the ZAP70 and also the Notch1 mutation, which reduces CD20 expression, so you're less sensitive to rituximab. But they don't change management at the moment, so we wouldn't routinely test for them. Okay, so we can't cure CLL, David. So therefore, it's one of those conditions where we must decide when to treat. And I guess in haematology generally, that's kind of taken me quite a long time to sort of get my head around. These sort of more chronic conditions, they're generally less sensitive to any treatments that we have in terms of traditional chemotherapy, because traditional chemotherapy obviously works by disrupting the DNA in cells that are proliferating and are within cell cycle. And so if they're not always proliferating, then they're less vulnerable to traditional chemotherapy. And so when you've got these chronic conditions, actually you need to be able to justify why you're putting that patient through the toxicity of treatment. So in what situation, you've got a patient, you've diagnosed them with CLL, they've met the 3 criteria that we've said, we've worked out their prognosis, and we've done the CLL IPI. And in what situations would I then go on to do, well, we haven't done all of the CLL IPI actually, because we wouldn't have done the mutation screening yet. But let's say I'm thinking, okay, maybe I want to start treating this patient and I'm going to send off the mutation screen and maybe get a CT scan. What situations would make you want to treat somebody's CLL?
So I'm sure there's some clever criteria. Most hematologists like to have a list of things.
We do.
But I'm saying, yeah. But I guess if I'm sort of pulling things from the staging that we did earlier, I imagine sort of top of your list is when it starts influencing other sort of cell groups. So any kind of cytopenias, it's probably high on your list.
Absolutely.
And we talked about nodal disease in various locations. So if that's starting to be, I guess, large, disruptive, or sort of all over the place, I imagine that would probably be when the patient's like, I'd really like you to do something about it as well.
Yeah, absolutely. So the two that you've picked up on are actually the two most important ones out of what's called the IWCLL criteria. So the International Working Group for CLL created a criteria for when to treat CLL. And there's 7 different criteria that they have. But I would argue that clinically, the two most relevant ones are cytopenias, so a hemoglobin of less than 100 or a platelet count of less than 100, aka stage C, I guess, by the initial staging, the Rye staging, but also the Binet staging, sorry. But also the other thing is bulk. Okay, so in terms of lymph nodes, a couple of small lymph nodes in the neck, groin, that wouldn't be a reason to treat. But when you're getting up to sort of greater than 10 centimeter lymph node mass, then that would be. But often, if you've got a bit of constitutional symptoms as well, with a bulk maybe not quite reach 10 centimeters, obviously you don't wait and go, oh, sorry, you're 9.5 centimeters, we can't treat you yet. But bulk and cytopenias are two of the most important ones. Constitutional symptoms is the third one. So feeling just really rubbish and having a really bad quality of life, which can be tricky to treat on the basis of that, because it might, if they're feeling really tired and that's their main symptom, that might not respond to treatment, or it might even get worse. The other thing is autoimmune disease. So autoimmune hemolysis, or ITP, that we think is secondary to that lymphocyte clone. Fourth or fifth, I've lost count now, extranodal disease. And then also the spleen. If you've got a big spleen that's more than 6 centimeters from the costal margin, or if it's progressive or causing a lot of symptoms like early satiety or left upper quadrant pain, then that would be an indication to treat. And then the last one that patients seem to get really hung up on more than clinicians is the lymphocyte doubling time of less than 6 months, or a more than 50% rise in 2 months. And that's just about acknowledging that if you've got a patient that's got a rapid rise in lymphocyte count, then, you may want to start treating them before they start getting into trouble from it. But that one is a softer indication for treatment. And really, a lot of people won't take that one seriously until the lymphocyte count is at least 30. Because, if your lymphocytes have gone from 5 to 10 in 2 weeks or 2 months, that's not really going to concern you much to start treatment. But if your lymphocytes have gone from 50 to 100 over the space of less than 6 months, then that might make you more interested. So that's your criteria. And before you start treatment, you need to think about a couple of other things. So you need to think about the past medical history of the patient, in particular focusing on whether they have any cardiac or renal function issues. Secondly, their drug history, because the treatments that we're going to talk about do have interactions with other medications. And then thirdly is going to be sort of the biology of their disease. So what is their TP53 and their IGHV gene mutation status? Okay. And then when we talk more about treatment, which we'll go on to talk about now, there is no right answer necessarily in terms of this is the best thing first line for all patients. And so there's going to be a lot of shared decision making in the absence of sort of head-to-head trials, where actually it's about tailoring what's important to that specific patient and then picking the best treatment based on that.
Yeah, makes sense. I guess, there's quite a few things there. What happens if my patient doesn't quite reach that criteria? What if their doubling time's a bit slow and, they don't have huge sort of bulky disease? What do we do? What are we doing then?
Yeah, I think that's a really relevant question that you asked, David, because as we said at the beginning, over 80% of CLL diagnoses are coincidental. And so many, what we call stage 0 or stage A CLL, we can just watch and wait. And often that can be as a shared care in a lot of different places with the GP practice. So you can diagnose the patient with, stage 0 CLL, write a letter to the GP saying, please do some relatively frequent full blood counts and let us know if anything becomes an issue, and give them sort of the list of IWCLL criteria to kind of get back in touch with us. that's quite sort of area dependent. But even patients that are managed just as a watch and wait, I think one factor that's really important to acknowledge in CLL is that the majority of deaths from CLL are due to infection, okay? Mostly bacterial infections. So I'm just going to say that again to kind of emphasize this point. The majority of deaths in CLL are due to infection. So what that means is patients that are on a watch and wait treatment where you're not needing to intervene to deal with the lymphocytes or deal with the lymph nodes, we still need to pay attention to the fact that these patients will not have as good an immune system as you or I, for example. And so supportive care is extremely important in all CLL patients. And I like to think of supportive care in terms of firstly vaccination, and then there's IVIG, so intravenous immunoglobulin, prophylactic antibiotics, and particularly with COVID, that's been quite an area of concern for the community of CLL patients. So in terms of vaccination, they need to avoid live vaccines for the rest of their life. So no yellow fever vaccine, for example. They need to have seasonal flu vaccines, and they also need to have their pneumococcal vaccine. So they need to have the Prevnar 13 conjugate vaccine. And then after a 2-month gap, they then need to have their Pneumovax 23 polysaccharide vaccine. And once they've had those 2 vaccines, they then need that repeated every 5 years. And in patients that get recurrent or severe infections, you may also want to assess their antibody response to those vaccines to check they've actually made an antibody response.
Yeah, I was about to say, if they're going to have a bunch of useless lymphocytes, the chance of them making memory is probably a bit hit or miss.
Yeah, absolutely. So sometimes patients will go to a private immunologist with a whole battery of antibody tests and say, "Doctor, what does this mean?" Remember that that's only one element of immunity, and that you've still got your T-cell immunity, which can be very important in providing immunity to things that we can't yet measure in the same way. But particularly with the pneumococcal vaccines, that is an example where actually testing the antibody response can be really useful, particularly if you think the patient will benefit from IVIG. They should have the COVID vaccine and boosters whenever they come out. And the other thing that's a bit exciting for these patients is the Shingrix vaccine, which is the new varicella vaccine, which is recombinant rather than live.
I have so many questions by so many people about, can I have the shingles? So that's I can go back now with a big grin on my face and
so
look
Shingrix,
smug.
Yes, but
Okay.
Not the old one.
Okay,
which
great.
I think is called Zostavax or something. But Shingrix is the new recombinant one.
Lovely.
Yeah. And so then
Grand.
the other option is IVIG. So when you measure the patient's immunoglobulins, which we were talking about at the beginning, you measure their total IgG, IgA, IgM, and you'll often see low antibodies that we call immune paresis. And if they are significantly hypogamma, so their IgG is less than 4, and they get recurrent infections despite 6 months of trial of prophylactic antibiotics such as azithromycin, and they fail to respond to the polysaccharide pneumococcal vaccine, then they are funded to have IVIG replacement to help boost their immunity. But there are quite a few hoops to jump through to get fund access to that because it's expensive. The other thing is prophylactic antibiotics, and that can be very useful for anyone who gets recurrent or severe infections, and usually is azithromycin because it's usually chest infections that they get. And then the other thing is PCP prophylaxis, which they don't need when they're not on treatment, but you should definitely be considering when they're on treatment, particularly if they're having second line therapy, because once they've already had 1 line of therapy and a background of CLL, they've got really quite a vulnerable immune system, and they should probably have PCP prophylaxis during treatment and for 6 months after, or until their CD4 count recovery. And then the other thing to say is about CLL, which, as we said, has caused some major anxiety to the CLL community and really made quite a lot of patients sort of feel unable to resume participation in society. And I think that was fair early on because initial data during the pandemic did suggest a mortality of up to 1/3 in CLL with COVID. And we know from the UK CLL VR study, in which 500 patients with CLL were vaccinated, that their antibody response rates are quite poor. So I think it was 67% versus 100% in healthy controls. Particularly their antibody response to COVID vaccines was poor if they were on a BTKI, which we'll talk about in a bit, but also if they have low immunoglobulins or if they have advanced stage disease and they're just about to start treatment. The encouraging thing, though, is that many of them did improve response to COVID vaccines with repeated doses of booster up to the fourth. So once they'd had the fourth dose, a lot of them then did get a response, but 20% didn't make a response despite repeated doses. So if possible, the BSH recommends trying to get a couple of doses of COVID vaccine in first before you start treatment, if possible. And then, of course, if a patient does have CLL and gets COVID, they should be made aware that they may well be eligible for the COVID medicines, so things like Paxlovid and remdesivir. And then there was also this monoclonal prophylactic antibody, which has been MHRA approved, called Evusheld, which you might have heard in the news, which unfortunately hasn't been funded in the UK. And so patients can access it via some trials like the Rapid Protection Study, but it's not NICE funded, unfortunately, and you may have patients coming and asking you about that. But the rate of hospitalisation now in the Omicron era is about 7% in vaccinated CLL patients. And so I think there is a real move to try and encourage patients to start living a more normal life in terms of their quality of life in this era of which we now have COVID. So that's support.
I imagine these are questions that you probably get a lot from GPs. I imagine this kind of information is quite hard to dig out. And I imagine the sort of, when switch rings and you're like, oh, here we go again, it's going to be a GP asking how am I supposed to deal with this? So it's useful that there are some guidelines there.
Yeah, definitely. So do you know of any treatments then for CLL, David?
So you've set me up. So I heard you mention the BTK inhibitors. So I know there's going to be an ibrutinib or some kind of brutinib in there somewhere.
Yeah, exactly. And I think the first thing to say before we discuss anything further about treatment of CLL is it's become a really exciting and cool area of hematology again, because over our lifetime, even just over the last 5 to 10 years, the treatment of CLL has had a massive paradigm shift. So we have moved from an era where we were using chemoimmunotherapy, so things like FCR, which is fludarabine, cyclophosphamide, and rituximab, or Arbenda, so rituximab, bendamustine, and chlorambucil-based regime. So really traditional chemotherapy with lots of toxicities. And we've now moved into this completely brand new targeted therapies era in CLL, which was really brought about by 2 pivotal trials. The Alliance trial, which was published in New England Journal of Medicine in 2018, in which they looked at Arbenda versus ibrutinib and rituximab versus ibrutinib monotherapy in those with CLL over the age of 65. And both ibrutinib-containing arms had improved progression-free survival compared to bendamustine. And then also the Mayo Clinic study, which looked at ibrutinib rituximab versus FCR. And again, ibrutinib rituximab improved progression-free survival and overall survival of these patients. And then more recently, obviously, the UK-based trial FLAIR that was published in Lancet Oncology in 2003, earlier this year, also backed up that data to say rituximab ibrutinib versus FCR improved progression-free survival. So there's now a very limited role for traditional chemoimmunotherapy because we're getting better results with the targeted therapies and generally less toxicity. But
I imagine that's kind of important with our patient group being quite so, well, the older they are and the more frail and the more comorbidities they have. Yeah.
Absolutely. And actually COVID was helpful in accelerating this because it accelerated funding for these targeted therapies to try and keep patients out of hospital and not having traditional chemotherapy like FCR. So that allowed us to get lots of real world data and to start getting familiar and comfortable with these drugs maybe quicker than we otherwise would have done in CLL, which has been really good. But I think there is the new challenge of treatment in CLL is about which of the targeted therapies is right for a patient, because there are no head-to-head trials between the different types of targeted therapies. And the progression-free survival is similar in all of them. There is now emerging evidence or a general feel within the CLL community that TP53 status is important. And this came from the German study CLL14, which was looking at venetoclax, and we'll go into the different targeted therapies in a minute. But venetoclax trial CLL14 contained 17 patients which had a TP53 mutational deletion, and they were noted to not do as well, with a reduced duration of progression-free survival, which was a bit worrying. And the Illuminate trial, which was a trial where people were on continuous ibrutinib therapy, they didn't see so much of a difference with TP53 mutational deletion. And so there is a sort of suggestion and general consensus that is building that if you are TP53 mutated or deleted, then continuous therapy is probably better than a fixed duration therapy. And so that will influence which targeted therapies you choose. But other than that, it's about talking about the side effect profiles and picking the right drug for the patient in a sort of shared decision-making process.
Okay, so we've got lots of fancy new MABs and NIBs and such. Is there any role for the traditional chemotherapy, the FCRs that you mentioned previously?
Yeah, that's a good question. Fludarabine, cyclophosphamide, and rituximab can still be used if a patient is TP53 intact and has a mutation of the IGHV gene, and they're young and fit. Then you could still offer this chemoimmunotherapy option, with the advantage being that how it works is you give a certain number of cycles until MRD is achieved, minimal residual disease, with a maximum of 6 cycles. And so some people might want to do that because it's time limited treatment and can give you very good duration of response. But I would say in the era of now having venetoclax, the Veno regime, actually that's also time fixed to certain number of years, and doesn't have the increased risk of MDS and AML that having traditional chemotherapy carries of about 2%. So actually I would say probably the main benefit was that it was time limited therapy, but we now have time limited like selective inhibitors. So I would say that probably there's no real role for FCR anymore. So talking about the different types of targeted therapies, you mentioned ibrutinib. Do you know anything about ibrutinib, David?
So from what I understand, it's a Bruton's tyrosine kinase inhibitor.
Yeah.
And the tyrosine kinase pathways are something to do with B-cell receptor activation.
Yeah.
That's about as deep as I can go. Yeah,
no, that's a good start. So if you think about CLL lymphocytes, I kind of think of them of sort of holding hands with each other using their sort of B-cell receptor. I don't know if that is exactly true or not, but certainly they receive signals via their receptors on the surface, which tell the cells where they are and encourage them to proliferate or not proliferate, which is why if you have an intercurrent infection when you've got CLL, you can get quite dramatic lymphocyte rises where people will phone and say, oh, I think they've got progressive CLL. And it's like, no, it's actually just an exaggerated response to infection. And so what you can do is actually disrupt those lymphocytes and get them to become more vulnerable by blocking the intracellular signaling of the B-cell receptor. And the Bruton tyrosine kinase is basically a molecule that will then phosphorylate things downstream of the BCR, the B-cell receptor, and therefore kind of disrupts their function. And so that's basically how it works. So it blocks off the receptor that is needed for the lymphocyte to receive survival signals and proliferation. And so they will then die off by apoptosis, basically. And that explains why when you use your Bruton tyrosine kinase inhibitors, you often will get an initial what's called redistribution lymphocytosis, where the lymphocyte count actually goes up after you've started them on ibrutinib and you think, oh, hang on a minute, this isn't working. But then actually it's just, I kind of think of it as the lymphocytes have gone into the blood because they've got confused as to where they are, and then they start dying off. And so usually that will last about 8 to 12 weeks, and you just hold your nerve, keep going with the ibrutinib. It can last up to a year, and it can also, so that's how Bruton tyrosine kinase inhibitors work.
It sounds quite clean, considering it's sort of using its own sort of apoptotic mechanisms.
Well,
does that mean that the side effects are relatively well tolerated?
So ibrutinib is a first generation Bruton tyrosine kinase inhibitor, which means it's less clean. So it's given as a once a day dosing of 420 milligrams once a day. And yes, it's cleaner than traditional chemotherapy for sure. You know, you don't lose your hair or have diarrhea or nausea or anything. But ibrutinib has a side effect of AF of about 16% and hypertension in about a quarter of patients. And it also has a side effect where it has a bit of an antiplatelet effect and can cause major hemorrhage, in which a meta-analysis has shown a sort of relative risk of 2.7 of any form of bleeding. So quite a significant increase in bleeding risk. And the FLARE study also demonstrated that it increases your risk of sudden cardiac death, particularly in patients with hypertension or a pre-existing cardiac disorder. So it is clean, but it does have these quite significant side effects. So in terms of the bleeding risk, you must avoid warfarin for patients with CLL on ibrutinib, and you should use a NOAC if they need to be anticoagulated. And we generally try to avoid dual antiplatelet therapy because they've kind of got a bit of an antiplatelet effect going on already. The reason why we don't know how safe using NOACs is in ibrutinib, we know that the patients who were on warfarin with ibrutinib in early trials developed major hemorrhage and subdural hemorrhages, and so then were excluded from the early trials. But we don't really know what the effect of being on a NOAC with ibrutinib is, but certainly we do it if it's needed, for example, for AF or a PE. We also hold ibrutinib before operations. So, for example, if it's a small operation or a small bleeding risk like an endoscopy, maybe for 3 days before, but if it's major surgery, 7 days before. And that's worth bearing in mind because actually it's best to try and get those operations done before starting the ibrutinib, because once you've established them on treatment, you kind of want to keep them on treatment for about 6 to 12 months to avoid sort of regrowth of disease during short periods of holding. But you can hold it no problem for sort of 3 or 7 days once they're established on treatment. And then the other thing is that they have quite a lot of drug interactions. So they interact because they are dependent on the CYP3A4 enzymes in the liver. And so you need to avoid concomitant CYP3A4 inhibitors, such as all the azoles like ketoconazole, itraconazole, voriconazole, posaconazole, so your antifungals, as well as clarithromycin, and then also Seville oranges and grapefruit. So if you like marmalade, then that's quite bad news for you.
Just palliate me. I'm done. I'm not taking not doing the jams.
And then diltiazem, verapamil, and amiodarone as well can interact. If you need to use a long-term CYP3A4 inhibitor, so for example, if you absolutely had to have your marmalade every day, that's obviously not a real example, but then you would just need to reduce the ibrutinib dose so that you don't overexpose them. And likewise, you need to avoid inducers of CYP3A4 because they can decrease your ibrutinib plasma concentrations. So things like carbamazepine, rifampicin, and phenytoin. So generally quite clean. And I guess the other thing to just say with each of these treatments is knowledge of the trial that has led to us using them is useful. So in the case of ibrutinib, it's the RESONATE-2 trial. And that basically showed that indefinite ibrutinib therapy versus less than or equal to 12 cycles of chlorambucil, you had an improved depth of response, improved progression-free survival, and an increased overall survival. And that's why we've moved from chlorambucil to ibrutinib, for example. But we now have a second-generation Bruton tyrosine kinase inhibitor called acalabrutinib. And this is a tablet that's taken twice a day, so 100 milligrams BD. But it has a much cleaner kinome than that of ibrutinib. So your rates of AF are only 4%. Your hypertension is 2%. Your bleeding risk is 2%. It comes with a bit of a headache sometimes, but we found that by drinking caffeine, that helps with that headache. And now most people prefer using acalabrutinib than ibrutinib. And I think we might be sort of seeing the end of ibrutinib in terms of its sort of use when we know that acalabrutinib is safer, particularly in terms of cardiac toxicity. The trial that led to the use of acalabrutinib was the Elevate-TN trial. And that was acalabrutinib plus or minus obinutuzumab versus chlorambucil obinutuzumab, and it showed, again, improved progression-free survival at 4 years. So that's the second generation one. But then we also have a different class of sort of targeted therapy. Have you heard of any other kinds other than Bruton tyrosine kinase inhibitors?
So, I mean, we've mentioned venetoclax.
Yes. What do you know about
little, if I'm honest. I think I've heard it has something to do with helping apoptosis or preventing the cell from ignoring apoptosis, something like that.
Yeah, absolutely. So venetoclax basically works because in health, what happens is when you get a mutation in your DNA, your P53 will then cause an increase in BAX, and BAX comes and drills holes in your mitochondria and then triggers apoptosis. And there's a protein called BCL2, which basically protects the mitochondria from these holes being drilled by inhibiting BAX, and therefore BCL2 resists apoptosis. And so what venetoclax does is it inhibits BCL2 and therefore allows apoptosis to occur. And actually thinking about apoptosis is a really useful way to describe the disease process of CLL to patients, because I kind of describe it as it's not an aggressive condition where you've got a mutation that's driving cell proliferation per se. It's more that your cells have become immortal and are not very good at dying when they're supposed to and not undergoing programmed cell death, apoptosis. So it's a bit like, instead of turning the tap on full in the bath, you're just unable to remove the plug to let them drain away. And so you'll slowly accumulate lymphocytes. And I think that can be really helpful for patients to visualize.
Yeah, I'm definitely going to steal that.
Yeah. So venetoclax is a tablet, 400 milligrams once a day, and it can be used both in the frontline and the relapse setting. Frontline setting, it's a 1 year fixed duration, and it's OVEN, obinutuzumab and venetoclax combined. In the relapse setting, it's a 2 year duration, and it's venetoclax rituximab, so VEN-R. And essentially, venetoclax is a really exciting drug. The study that showed this was the CLL-14 study, which was the German one, looking at venetoclax obinutuzumab versus chlorambucil obinutuzumab, and showed improved progression-free survival at 4 years with very durable remissions after stopping therapy. And that's what was really exciting about venetoclax compared to the Bruton tyrosine kinase inhibitors, which are a continuous therapy, meaning that with ibrutinib and acalabrutinib, you keep taking the tablet either until disease progression or toxicity that means you want to stop. As with venetoclax, it was fixed 1 year duration, frontline, 2 year duration at relapse, and very high rates of minimal residual disease of about 75%. But so that's really exciting. And this was another big breakthrough in CLL. But the early trials of venetoclax were quite stressful because they had lots of patients die. And initially it looked like it was going to get completely canned, but they were dying from Haemolysis syndrome. And somebody then realized, okay, what if we use like a fraction of the dose that they were using? And this was in the phase 1 studies, and they then found you could use it safely. So basically, it's very effective at killing cells, and it can be too effective and cause Haemolysis syndrome, which can lead to... Are you familiar with Haemolysis syndrome, David?
Yeah, so from what I understand, there's a lot of stuff in cells that should really be inside cells, a lot of electrolytes and such, so you let them free, and that's going to cause a huge amount of problems. And I understand, like, your immune system was also sort of geared to look for things that shouldn't be outside cells when things die, not via apoptosis or biomechanisms that go a bit quick. You end up in a lot of trouble.
Yeah, so, I mean, Haemolysis is really just all about the potassium being released, phosphate, calcium going down. and lots of urate, which can accumulate in the kidneys and cause very bad kidney damage, which can produce a vicious cycle, high potassium, and then arrhythmias. So that's why it's deadly. So in OVEN or VENO, first line, we actually give 3 doses of obinutuzumab first. And I realise I haven't really explained what obinutuzumab is. Do you know what obinutuzumab is?
I was going to sort of mention it, but I was like, you seem to be flowing too well on that one, as if it's something I should know. So yeah, no, please enlighten me.
So obinutuzumab is very similar to rituximab. They're both monoclonal antibodies against CD20, so expressed on B cells. Obinutuzumab is kind of seen as the more powerful brother of rituximab. It has a lot more antibody-dependent cell cytotoxicity, and so kind of produces stronger results but more toxicity, but is, for whatever reason, what was chosen to be used with venetoclax in the CLL14 trial frontline, which is why we use it. So what you do is you give 3 doses of obinutuzumab on day 1, day 8, and day 15. And that's really useful because that can actually bring the white cell count down and the disease burden down quite a lot before then starting venetoclax on day 22. And that can therefore reduce your risk of tumour lysis. And so you then have to stage your tumour lysis risk after your third obinutuzumab by doing the CT scan of your neck, chest, abdo, pelvis to look for bulky disease and see what remains, as well as obviously doing your full blood count to look at your white cell count and how high that is in combination with your kidney function. And you can then risk stratify into low, which is where all of your lymph nodes are less than 5 centimetres and your absolute lymphocyte count is less than 25. Medium, which is where you've got lymph nodes are greater than 5 but less than 10 centimetres in size, or an absolute lymphocyte count of greater than or equal to 25, or a creatinine clearance of less than 80. And then high risk, which is where any patient who's got more than 10 centimetre lymph node, or an absolute lymphocyte count of greater than or equal to 25, and lymph nodes between 5 and 10 centimetres. So that's your risk stratification, and that's really important because that then allows you to decide, can I start venetoclax in this patient as an inpatient if they're high risk, or can I do it on a day unit if they're mid or low risk, okay? And then we have a sort of ramp of the dose as well. So we start with week 1, where we just give a 20 milligram dose tablet, and then we test their bloods 4 hours and 8 hours post, and then the next day as well before they take their next tablet. And then if everything's stable, they continue for a week on 20 milligrams. And then they come in on Monday and they do the whole thing again, and they increase to 50 milligrams with tumour lysis bloods afterwards. And then 100 milligrams the week after that, then 200 milligrams the week after that. And then by week 5, they're on 400 milligrams once a day, which is then the like full dose. And then what they do is they carry on with that venetoclax 400 milligrams once a day for 1 year. And they have monthly obinutuzumab infusions at the beginning of each month for 5 more cycles. And then from cycle 7 onwards, it's just venetoclax monotherapy until the end of the year. So it can be a real pain for patients to be put on venetoclax at the beginning because of all these outpatient appointments on the day unit or an inpatient admission. But once they're established on it, actually, it's quite well tolerated. About 50% of patients did get a grade 3 neutropenia in the CLL.
Yeah,
study.
I was just thinking to myself, it does seem like, as opposed to maybe Bruton's tyrosine kinase inhibitors, anything that sort of pokes holes or stops an apoptotic process or, encourages it by inhibiting a negative inducer, that's not going to be specific to the CLL cells. That's going to be surely going to cause havoc with other cells.
Yeah.
So, I was going to ask about neutropenias or other sort of...
Yeah, you're right. And you do get more neutropenia, but, they don't get mucositis or any of the other things that you might expect. And the neutropenia sometimes needs dose interruptions, but can sometimes be managed with a bit of GCSF and often will settle after an initial neutropenia. The other big thing is the infusion-related reactions with obinutuzumab, particularly if you've got a very high white cell count, lymphocytes of 200 or something, or bulky disease. On day 1, giving obinutuzumab, if you imagine, the more disease you've got, the more your antibody will bind to the disease and then cause quite a big immune response, which can be quite dramatic, with sort of resus trolley being called and dropping their oxygen saturations and things. And that can sometimes make it really difficult to get the obinutuzumab dose into the patient. So although it's beneficial starting with obinutuzumab before the venetoclax to bring their disease down, but to reduce their risk of tumor lysis, sometimes, certainly at my hospital, we have ended up admitting high-risk patients for the first dose of obinutuzumab because we ended up admitting so many people with reactions from the day unit because they hadn't quite recovered their observations by the end of the day. But the major advantage of Ven-O compared to ibrutinib or acalabrutinib is you're done in a year. And there are really good response rates, apart from those sort of TP53 mutated patients where perhaps they benefit more from a continuous therapy. So that's venetoclax. And then finally, we've got this drug, which I'm terrible at pronouncing, called idelalisib, which, to be honest, I've never seen anyone actually on. It's a PI3 kinase inhibitor. There was initial excitement about it. So it's another blocker of a downstream mediator of the BCR receptor. But actually, it causes cases of life-threatening colitis and pneumonitis. So you've got to be really careful using it in anyone with pre-existing GI or pulmonary disease. It can derange your liver quite significantly. It also can lead to CMV reactivation. So you have to monitor for that. And there were quite high rates of PCP, so you need PCP prophylaxis. And so really, you're not going to see many patients on this. And it's really used now. It's kind of found its role as third-line treatment when you've got patients that are termed to be double refractory or double exposed, where they've had a BCL2 inhibitor, like venetoclax, and they've had a BTKI, like ibrutinib, and they've progressed through both those or failed to respond. Then you can use this PI3 kinase inhibitor to bridge them for a short period, and you try and minimize how long they're on this drug just because it is, it has got some quite serious side effects.
So that would be different to a relapse. That would be someone who hasn't sort of picked up on what would be your first and sort of second line treatment.
Yeah. So, but if you relapse after having had first
Both
and second line treatment, then again, your options are more limited.
Okay.
So I guess the next thing to just quickly touch on, which is becoming quite a hot topic with sort of recent publications, is what about the high-risk CLL patients? So these ones that are TP53 mutated or deleted and are young and fit, which obviously most of these patients are older, so you've got to bear that in mind. But can we do something to help these patients do better? And one of the things that's being explored is combining targeted therapies together. So doing doublet therapies, and that's probably the best way forwards, first line for these patients. So two of the studies, there's one by Jane et al. Published in JAMA Oncology in 2021, which was a phase 2 trial where you had ibrutinib and venetoclax used together as a combination therapy for first-line CLL treatment, particularly in patients who were picked out to be high risk based on their mutation status. And they had a pretty good 4-year progression-free survival of 90%. And the treatment was of a fixed duration of either 2 or 3 years, depending on their minimal residual disease status. So that's one option. The other big trial was Captivate, which was published in Blood in 2022, which combined venetoclax and ibrutinib in patients less than 65 years old with a TP53 deletional mutation or unmutated immunoglobulin HV. And they did 12 cycles fixed duration again, so a year of just Ven and I. And they found a 60% MRD rate, but one of the issues with it was tolerance of this therapy. So venetoclax plus ibrutinib, quite a lot of neutropenia and diarrhea and things like that. They're even looking at triplet therapies, combining 3 different things. So there's the AVO trial, which is acalabrutinib, venetoclax, and obinutuzumab, hence the AVO, at first line for patients enriched with high-risk disease, and also the CLL2 GIVE trial, which is a triplet with obinutuzumab, venetoclax, and ibrutinib as first-line therapy. And both have very good 3-year results. But the question is a triplet therapy necessary? Is it necessary in terms of toxicity? And is it necessary in terms of cost to the NHS, which is the other thing you need to think about?
I was going to ask, is the reason we don't just go in heavy with the triple from the get-go, is that usually because people won't be able to tolerate it, ignoring the fact that we have no money to spend?
Well, I mean, partly, yes, but also it hasn't really been studied up until now because, as I said, this is all of these drugs have kind of come about over the last 5 or 10 years, which is, not very long. But certainly it might be that the CLL treatment starts to go in the more double therapy direction, maybe triple therapy. I think the other really important thing to talk about in terms of identifying high-risk CLL patients, as well as thinking about first-line upfront double therapies, the other thing to think about is allogenic stem cell transplant, which we need to be thinking about referring our patients for early if they progress through their first therapy. So let's say we have a TP53 mutated patient started on acalabrutinib, lymphocytes come down, they're feeling good, everything's looking good, and then their lymphocyte count takes off or their hemoglobin drops and you marrow them and their bone marrow is full of CLL. These patients you should be referring for consideration of an allogenic stem cell transplant at that first progression, because what you don't want to do is end up with double exposed patients where you've then given him venetoclax, obinutuzumab, and he hasn't responded, and then at that point you're really desperate to get to an allo and having to hold with a PI3 kinase inhibitor, for example. So referring early after first progression for these high-risk patients is important. So that's first-line treatment of CLL. What about when they relapse? It's simple, really. Just to be clear what the difference is between primary progression versus relapse. Primary progression is where you've had less than 6 months of response. That's primary progressive disease. Relapse is when you've had more than 6 months response and then your disease has got worse. And again, when a patient relapses, you don't need to jump into treatment. Remember your IWCLL criteria for needing treatment, okay? It might be quite tempting, the lymphocyte count's going up, let's start second-line treatment. No, you don't. Again, you need to justify the toxicity of that. But when they do reach criteria for treatment, then it's all about class switching. So if they've had acalabrutinib, you're going to give them venetoclax. And if they've had venetoclax, you're going to try, acalabrutinib, for example. It's about switching the class of what you've already used to something different. And the venetoclax in the relapse setting is used with rituximab, in which actually you start with venetoclax and add the rituximab in later, just because of how the trial was done for that, which was the Marrow trial. And that's rituximab bendamustine versus venetoclax rituximab in the relapse refractory CLL. The other thing that's starting to be investigated is zanubrutinib, which is another new Bruton tyrosine kinase receptor inhibitor. And that's being looked at by the Alpine trial, which was just published in the New England Journal of Medicine this year. And they looked at zanubrutinib versus ibrutinib and showed that progression-free survival was significantly longer with the zanubrutinib and that it was much safer with fewer cardiac events. And that's what I mean about, I think ibrutinib has probably reached the end of its lifespan. And now we're going to be moving to second and third generation BTKIs. And then we talked about transplant. So if you're young and high risk with bad TP53 status, you need to change class and refer for an allo at the same time. If you're not high risk, then you need to switch class. But if you progress after that second line of therapy, that's when you'd be referring for an allogenic stem cell transplant. And remember, always retest your TP53 status before each line of treatment. Okay, so just because they weren't TP53 mutated at the beginning doesn't mean they haven't acquired that mutation, and that's important to know.
Okay. And I imagine if someone relapses, that's a similar process going forward with regards to class switching and things like that.
Yes, yeah.
Right. So where's the treatment going? What's the future? We seem to have made huge leaps and bounds.
Yeah.
What's next? What's on the horizons?
So I think trying to identify those that are poor risk disease and trying to intensify treatment for them, for the ones that are fit for it, which is one of the directions. So with the double and triple therapies. I would say the other big thing is that people don't want to be on treatment indefinitely. And so I think there's a big move to looking for more time-limited therapies and to reduce time on therapy for patients. For example, there's the static trial, which is looking at patients on ibrutinib and when it's safe to stop. I think the other thing that's going to become more interesting is using MRD in CLL. So minimal residual disease, or MRD, is currently only really done for trials where you use flow. And the reason why we're not currently doing flow at the end of therapy, like after let's say we've got a patient, they've had venetoclax obinutuzumab for a year, we don't routinely redo flow to assess their response to treatment because there's no clinical role yet. So what I mean by this is if they come back as minimal residual disease negative, then fantastic. You can be like, well done, everybody. You're likely to have a really good progression-free survival. But what if they come back as MRD positive at the end of treatment? Does that mean we should carry on the venetoclax for longer? We don't know yet. And so that, I think, is going to be another big question that studies by Jane et al. Are going to be looking at. So looking at using MRD status at the end of fixed duration treatment to determine whether they then go on to have a bit more treatment and what that does. So I think that's where we're going to be going.
Yeah. So how to use our new weapons effectively.
Yeah.
And
basically.
get people off them. Yeah.
Yeah.
How can we stop using these super good drugs that we've actually come up with?
Exactly. Yeah, totally. I guess some other specific treatment scenarios to just briefly cover in CLL is autoimmune hemolysis. So autoimmune hemolysis is one of the criteria for treatment by the IWCLL. However, only if it's not steroid responsive. And so really, if you've got a patient with CLL and they've got anemia, first of all, you want to work out, is this hemolysis or is this bone marrow failure? And a retic count will be really helpful for that, as it will be high in hemolysis and low in bone marrow failure. And a bone marrow biopsy will be helpful along with a hemolysis screen. But you've identified this patient's got a warm autoimmune hemolytic anemia. What you're actually going to do is start steroids and go down the treatment algorithm for autoimmune hemolysis rather than treating the underlying CLL. However, if they don't respond to treatment, that's when you're going to start directing your therapy against the CLL instead. And that's important actually because, actually sometimes when you start treatment for CLL, I've seen patients then develop cytopenias as a result of it. There was a patient that we had in clinic a couple of weeks ago who was actually pretty unaffected by her CLL, but she had a bit of an anemia from bone marrow infiltration. She was started on Ven-O and actually developed quite awful ITP that's been really difficult to manage. So treat the autoimmune condition first, but if it's not responding to treatment, then you need to think about treating the CLL. And about 10 to 20% of CLL patients get autoimmune hemolysis, and about 2 to 5% get ITP. So that's just something to think about. And then I guess another thing, David, just to say is if you've got your CLL patient, let's say they're on ibrutinib, you're seeing them in clinic and they say, oh, doctor, I'm having drenching sweats at night and I've lost a lot of weight recently. Do you think everything's okay? What would you be thinking in that situation?
I'd be concerned because those B symptoms worry me. I'm not sure where I'd go going forwards. I don't know if I would maybe be looking for something else going on.
Yeah.
Or whether I'd looking for something's changed. I don't know if I'd need to look at the cells again, potentially look at the bone marrow and make sure there isn't anything sinister brewing somewhere else.
And what do you mean by sinister? What is it that you're worried about in terms of this disease having transformed into something else?
I'm racking my brains. I'm thinking about lymphocytic and lymphocytes.
Yeah. So it's
you might have to help me.
That's fine. It's a B cell clone. So
Okay.
it can transform into other B cell problems, particularly high-grade lymphoma, so diffuse large B cell lymphoma. And we call this a Richter's transformation, when somebody's CLL transforms by acquiring another mutation into diffuse large B cell lymphoma. And typically they're the ABC type diffuse large B cell lymphoma. And so that's about 2 to 15% of all CLL patients can transform during their lifetime. And features that should make you think about a high-grade transformation, or if they get new bulky lymph nodes, if they've got a rapid lymph node enlargement, so all their other lymph nodes have gone down, but one is just starting to go up, that's always very worrying. Appearance of extranodal disease, B symptoms, as we described, or a very high LDH. A PET scan can be really useful in this situation to guide biopsy, because what you don't want to do is, if you think someone's got high-grade transformation, you don't want to just get a random lymph node biopsy, because it might just show you CLL or SLL, and that's not going to help you be reassured. You want to do a PET scan to look for the area of increased avidity in a single site, and then that can target your biopsy, and that's what you want to go for. And also, if you have an SUV of greater than 10 on a PET, that's also highly suspicious of it becoming high grade, or infection, I guess, is the other big differential for that.
Sorry, what's an SUV?
It's just a measure of intensity of avidity on a PET. So above 10, you think about high grade disease. And so this is really important to pick up. And unfortunately, the overall survival of a CLL patient developing a Richter's transformation is dismal, about 8 to 10 months. And they're often treated with R-CHOP, or I guess R-Pola-CHP. I'm not sure if that's licensed actually in Richter's DLBCL, but you treat them as a high-grade lymphoma, and they'll initially respond, and then typically they'll lose response. And you try to get them to either an autograft or an allograft to give them the best chance of long-term survival. But unfortunately, even if you intensify the treatment, so there have been trials looking at intensifying Richter's treatment with things like R-EPOCH, but it doesn't improve outcomes due to toxicities, because these are patients that now have a high-grade lymphoma on the background of a really quite chronically impaired immune system, which can make them really vulnerable to neutropenic sepsis and infections. So that's a big area that needs to be worked on in the future in terms of trying to treat it better.
Yeah. What a joyous note for us to conclude CLL on.
So let's
if you're unlucky.
Let's finish with the 3 take-home messages, which I think are probably that CLL is chronic lymphocytic leukemia. We can't cure it, but we often don't need to treat it. But even if we're not treating it, we need to be thinking about supportive therapies. Probably the second point is that your treatment is divided into targeted therapies, in which venetoclax, obinutuzumab, and acalabrutinib are probably your best bet now, or your doublet therapies. And I guess don't forget supportive care. I'm going to say that again because it's just really important.
We all heard you screaming about vaccines, and if anyone forgets now, having heard this, woe betide.
Yes, exactly. Great. Okay, well, that's it. I don't have anything else to tell you about CLL at the moment, but I encourage you to go away and read about some of those trials and areas of sort of future research in CLL, because it's a very exciting and rapidly progressive area of haematology. Thanks again for listening to Basics to Brilliance Haematology podcast. If you enjoy our series, please don't forget to like, leave a review, and hit subscribe to never miss an episode. See you next time!